ఏమైంది వచ్చింది వచ్చింది ఇది వెళ్ళొస్తుంది
హెడ్ అండ్ నెక్ అదే చేద్దాం
ఇదేమో కొత్తగా పెట్టేదేమరా
లైవ్ అయింది
హలో హలో ఇది వస్తుంది హలో 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 లైవ్ ఉందా ఇవాళ దేనిలో యూట్యూబ్నా హలో ఇది వస్తుంది హలో ఇది వస్తుందా అవునా అవునా యూట్యూబ్లో దేంట్లో ఉంది లైవ్ అవునా సో మా ఫ్రెండ్స్ పంపిద్దాం బ్రో భరత్ ఒకసారి ఒకసారి మన ఎక్స్రే పీపీటీని డౌన్లోడ్ చేయాలి
ఎక్కడ ఉంది
యూట్యూబ్
వాట్సాప్ ఎక్కడ
లైవ్ స్టార్ట్ అయిందా
పాయింటర్ మైక్ ఉన్నాయా సార్? రెండు ఉన్నాయి.
Good morning, sir. Today's topic is intertrochanteric femoral fracture. It is a comparison study of a clinical and radiological results with a proximal femoral, that is PFN and PFNA and intertannel. This study was published in Medicina, and this study was done in Department of Orthopedics and Traumatology, Fethi Sekin Hospital, Turkey, and this was published in 2013.
2013.
23, sir. Sorry, sir. 2023.
మరి 2020.
Yes, sir.
Recent.
An introduction. Over a million individuals suffer from hip fractures every year, making it one of the most prevalent orthopedic injuries. And half of all hip fractures or intertrochanteric fractures are more common in the elderly and are more often it's a consequence of low energy trauma. So the dynamic hip screw implant was the gold standard previously for the intertrochanteric fracture, and but now DHS is not considered gold standard as it cannot support the unstable fractures, and the bone healing is significantly aided by the interfragmentary linear compression provided by the lag screw in the majority of proximal femoral nails. So these are cephalomedullary nails, and one or two lag screws integrated or locked lag screws and a wedge block that offers a rotational stability are more of PFN designs on the industry. So to treat the intertrochanteric fracture, the available devices are the DHS, the dynamic hip screw, and the CHS, the compression hip screw, and PCCP, percutaneous compression plate, and Madoff sliding plate, and also less invasive stabilization system with a distal femoral plate, and a gamma nail, and finally PFN, PFNA2, and interton and metaton. So just for the sake of knowledge, I am just depicting images. So first one is the DHS, and the second one is the compression hip screw, and third one is the percutaneous compression plate.
Go back. Compression hip screw. DHS. What is the difference?
It is the proximal part is angulated and the proximal screw is directed upward and medially, sir. And in this the cortical screws are all in they are not directed, sir. They are straight. They are parallel to each other.
Okay. That is PC. Go back. What is PCCP?
Percutaneous compression plates.
What are the indications of PCCP?
This is also used for intertrochanteric fracture, sir. Stable intertrochanteric fracture, not for unstable.
Stable intertrochanteric fracture and for
And these all three
and also for base cerebral and pressure.
These all three implants are more suitable for stable only, sir.
Stable, not unstable. Very good, sir. Good point.
And Madoff sliding plate, this is also for stable fractures, and it has same lag screw as DHS, lag screw and compression screw as DHS, and the barrel is designed in such a way, and it has screws in two directions with a 3 on posteromedial side and again 3 on anteromedial side in different direction. So this is for the better purchase into the cortex and better holding.
So vertical.
And sir. And the second one is a less invasive stabilization system. This is done with a distal femoral plate, and as shown in this image. And this is a gamma nail. Gamma nail has only one proximal screw that gives lag effect, and later I describe. And this is what we use regularly in our hospital is a proximal femoral nail. It has 6.4 mm cannulator bolt proximally and 8 mm cannulator bolt. This is a weight bearing screw, and this is more work like a, even though it gives some lag effect, it acts like derotation screw. But this screw also helps for the compression of the fracture side. And this is a PFNA newer design. So it has a helical blade. This has a helical blade. It causes micro fracture and micro bleeding at the fracture side and helps in the healing. So the distal anti-rotation, yes sir.
Prevents the derotation and better in osteoporotic bones.
Yes sir, better in osteoporotic and elderly people. And this is the intertan, the newest design. It has interlocked proximal screws. The two proximal screws, one is weight bearing and another integrated interlocked. So this design will give better construct, and it prevents the rotation. It acts against the rotational forces and stabilizes the head, and it gives better stability in the unstable fractures, and the distal tip is fluted like this, so it prevents the periprosthetic fractures. Stress riser effect it will reduce.
It cannot give the rigid construct.
Yes.
Go back, go to.
And
Go back. It has got a trapezoid construct.
trapezoid, next explanations.
So it has got a controlled stability, controlled compression, stability, and strength. Controlled
Yes, sir.
compression.
And the basic work principle for all cephalomedullary nerves is a controlled collapse at the fracture site with a stabilization. So all PFN, PFN-A2, intertan, metatan, and all DHS, they work all on the same principle. But the construct, the implant design is differs in the stability only. So the newer designs gives more stability, whereas DHS cannot give.
Very good, excellent.
And the aim of this study is to compare the three distinct PFNs. These are the most prevalent PFNs done in worldwide, and in our country also recently the intertan the intertan fixations were increased, and these are the three, one is PFN, one is the PFN-A, the PFN anti-rotation, and another one is intertan. So these three are compared in this study. And materials and method, it is a retrospective observational study conducted from January 2018 to January 2021, the 4 years, and a total of 309 individuals were evaluated. In the patients, 143 are males and 166 are females. So the inclusion criteria for this study is individuals with a unilateral isolated intertrochanter fracture who were mobile enough to undertake everyday task prior to the surgery, and at least 18 years old are taken into consideration, and whose follow-up period was at least 1 year participated in the study. And the exclusion criteria is non-trochanteric fractures, pathological fractures, polytrauma patients, bilateral simultaneous fractures, previous intertrochanteric fractures in the contralateral leg, impaired muscle strength, and mental disorders including dementia, and follow-up less than a year were the exclusion criteria for this study. So
Go back. Whenever you use the word exclusion criteria, we could have gone. So patients are not medically and surgically fit.
and mentally.
Sorry, better.
Mentally.
Follow up less than a year where the exclusion criteria mental is important. Patient should be mentally covered. So patient should be medically and surgically unfit. Medically and surgically unfit. Anesthetically, some people use the word anesthetically, medically, and surgically. It's 4 marks.
So these three PFNs are contrasted under several variables. These are the variables included in this study. That is the name and gender, body mass index, energy of trauma, whether it is low energy or high impact injuries, the length of staying in the intensive care, whether to be admitted in ICU or not, and mortality in the first year, clinical and radiological outcome of the fracture and patient, amount of transfusion, and preoperative time to the surgery, hospitalization time, and duration of surgery, and fluoroscopy. The fluoroscopy means how much time we used CM or any radiological instrument in the theatre, and the fracture type and reduction quality, and a complication ratio. So the functionality of a patient was determined with the Harris Hip score. They mainly included this Harris Hip score, sir. And the radiological outcome include the reduction quality, the fracture union, and radiological complications including V effect, Z effect, and varus collapse.
What is V effect?
Explanation, sir. Next. So for the sake of knowledge, I am describing the implant design. These three, the intertan and the PFN-A2 and the regular PFN, what we use in our hospital. So first we come to the intertan. So it has proximal 4 mm valve offset. Valve offset means it is a offset. It is about this is 4 mm. It is 4 mm away from the shaft. The line drawn from along the shaft. So like this, and it has a trapezoidal cross section with a 17 mm proximal diameter. So for the all intertans and all size intertan and metals.
It is in valgation or So
and
anatomical axis is there. So anatomical axis is there. Mechanical axis is there. Vertical axis is there, and transverse axis also.
so for all intertans, the proximal diameter is same for all. That is 17 mm, and the distal Here what we say in our theatre, like 9 mm, 10 mm, 11 mm, usually we talk about this part only, distal shaft part, and the proximal part is same for every PFN and same for every PFN8 and same for every intertine. So all intertines they made with 17 mm proximal diameter and 10 to 11.5 mm groove distal tip diameter here, and angles come from 125 and 130 CDA, that is a colodiaphyseal angle. That means colo means collar or the neck. So this is the angle from here to here. So this is the angle. So that is about 125 or 130 degrees.
That is something like neck shaft angle.
Neck shaft angle, yes. And well, CDA and bitter. And a lag screw of 11 mm and a compression screw of 7 mm were used. So this is the lag screw, this is the 11 mm screw, and this is the 7 mm screw. With a single distal screw that was locked in either in a dynamic or a static configuration. We have two holes, one is a dynamic or one is a static. So we can use either of the hole. With the combined proximal screw system, it was possible to achieve interfragmentary compression of up to 15 mm. So the fracture gap is about 15 mm reduction we can achieve. And this is the PFN-A design. It is available in two different lengths. One is 180 and one is 420. 180 and one is 420. This is a short and this is a long. And the top portion of the proximal nail features a 6-degree valgus angle, just like I explained before, and medial lateral, that is medial lateral curvature or valgus curvature, with a diameter of 15 mm. So for the PFN-A, the proximal diameter is 15 mm and the distal diameter is 9 to 12, 9, 10, 11 and 12. And it has a lag screw that compresses the fracture and a wedge block that provides rotational stability for femoral fractures. The 10 mm wide thread and 125 angle of the lag screw are consistent with the CDA. And the distal end, the wedge block is in the groove on the lower portion of the lag screw. And the distal end of the nail has two locking holes appropriate for either dynamic or static fixations. So this has a helical, this will have the helical blade. So it is not a rigid construct. With every movement patient, and this PFN and PFN-A are designed for early weight bearing or immediate weight bearing. So with the weight bearing, with the this helical blade, it causes micro bleeding and micro fracture at the fracture side and cause bleeding and hematoma formation, helps in better healing, better and fast healing. And this is regular PFN what we use.
See, it is like anti-rotation. The biomechanics acting at the level of the joint is the shearing forces are converted into
compressive.
So whenever DHS is, it rotates. So it is like anti-rotation. So it never allows for rotation. So it better gives better compression and better fixation. And the V effect, the Z effect will be less with the PFN-A. PFN-A, proximal femoral and
anti-rotation
nail, cephalomedial nail.
Yes.
Chances of V effect and Z effect are less compared to your PFN. Proximal femoral.
Yes, explain this, sir, next.
And you got a positive effect, negative effect and a neutral effect. Yes.
That is a reduction criteria. Yes. So for the PFN, the proximal valgus offset is 6 degrees and the distal groove, it is a distally groove shape, and it is attached with a 6.8 mm and 6.4 mm. 8 mm is a lag screw and 6.4 mm is a compression screw, and it also gives some lag effect. And the lag screws with 130 and 135 CDA, that is colodiaphyseal angle and neck shaft angle. The nail has 16 mm proximal diameter and the diameters of the distal is 9 to 12, 9, 10, 11 and 12. The both dynamic and static fixations with 4.5 mm or 4.9 mm or 5 mm locking screws are possible via the two distal holes. So in the two distal holes, the distal one is the dynamic.
We are using 4.9.
Mano 4.9.
This is some made, company made, titanium and others.
Other 4.5, 4.9 and 5 mm.
Very good, sir.
So in these two distal screws, the distal one is a dynamic hole, this the proximal one is a static hole. And coming to the study design, for statistical purpose, they have used IBM SPSS Statistic 22 software was used, and they are saying that this software is the latest in the country. And using the chi-square test, the Fisher-Freeman Holton test and the continuity correction and the qualitative data were compared. The p-value for this study is less than 5%.
0.05 less than 5 కాదు
5%.
నార్మల్ p వాల్యూ 0.05
05 అదే సార్ 5% or 0.05.
05 then significant. What is other name for p value? ఏంటి other name for p value? P value is short notes.
Probability.
Value of probability.
So coming to the results of the study, the total of 310 cases were evaluated, and that 143 are males, that is about 46.3%, and 166 are women, that is 53.7%. The age between 20 more of women, and age between 23 and 95, and the study was done between January 2018 to January 2021, 4-year study, and the mean age of
Stop. So what is the difference between 23 and 95? So both are belong to the same group, or there is some important? Which group is called as a non-Agerian group?
greater than 90 years.
90 years. So you are including the non-Agerian group also.
Yes sir, because they have used intertan and PFNA also, that is more suitable for elderly and osteoporotic.
In terms of osteoporotic.
Yes, that's why they are included.
There are more. Division also, sometimes they make also division also.
The mean age of the patient was 77.34 years. Simple FOSS are the most prevalent cause of injury across all categories, and 1-year mortality rate was 27.5% among 309 patients. In 66.3% of patients, anatomical reduction was achievable, whereas 7.8% of the reduction were of poor quality, and approximately 39.5% of patients had at least one complication, with 3-1-A2 fractures being the most prevalent kind of fracture. So they have taken the AO classification of a proximal femoral fracture. అది పెట్టలేదు సార్, I will explain.
A series are two-part fracture stable.
Yes.
A2 or two-part fracture medial
Unstable. Medial combination unstable.
And it can be more. It can be unstable. 3 is lateral column
And subtrochanteric region. Yes.
So you are talking about unstable, more of consanguine.
Also both stable and unstable, both they are taken. This is the complication rate is more sir in this category. Approximately 39.5% of patients had at least one complication. With the 3-1-A2 fractures being the most prevalent kind of fracture. That is the most common in that. The descriptive features of the patient. So they are included among 3 PFN designs, that is PFN anti-rotation and intertan, and the fracture classification is A1 is about 104 patients, A2 is about 179 patients, and A3 is about 26. The most common is a 3-1-A2 fracture, that is a unstable fracture.
Unstable medial combination, more than two-part fracture.
Yes sir. And in that patients, 187 patients have complications, and 122 patients have no complications. And the complication which they were taken into consideration are, most common complication is hip and thigh pain, and the second most common is a V effect, and the remaining all are very minor. Those are cutout rate and deep tissue infection, double screw back and hardware breakage, superficial infection, varus collapse, and urinary system infection, and Z effect and non-union. So these are the complications with the 3 models. So the main complication is hip and thigh pain. So that is more seen in PFN anti-rotation, and is less seen with intertan. And so in between is a PFN patients. And the second one is the V effect, and V effect it is more common with the PFN anti-rotation and also with the regular PFN, but it is very less, that is about only 3%, only 3 patients with the intertan. And the Z effect is only seen in the regular PFN, not with the intertan and not with PFN anti-rotation. And the non-union is seen only in one case with the intertan. So remaining all complications are more or less equal with the all 3 designs. So coming to the discussion, the current study is a comparison of the 3 most prevalent PFN models. The unstable fractures, that is aorta classification 3-1, A2 and A3 type, which are multifragmentary or have a displaced femoral neck, may be especially difficult to fix. and 90.1% of individuals experienced hip and thigh pain due to the gluteus medius muscle being scrapped following nail insertion. So this is a common for hip pain after intertrochanteric surgery.
Very good, sir.
So for unstable fractures, concluded that the intertand nail reduced implant related failure and implant breakage and reintervention rates and hip and thigh pain without impacting recovery results. And the intertand related treated individuals did not experience the Z effect. And compared to the intertand and PFN-A patients had significantly lower Harris hip score and CADS ADL values in the current study. When the fracture line extends all the way to the from the greater trochanter tip, an iatrogenic complication known as a V effect might occur following fixation with the PFN. And image I will show in the next slide. And the varus of the femoral neck with respect to the femoral shaft seems to be a direct result of V effect. And the V effect was most prevalent in the PFN-A group and least prevalent with the intertand group. And the V effect was found in 32.9% of 3-1-A2 type fractures, but in none of the 3-1-A3 type fractures, leading us to conclude that the surgeon should be careful when operating on 3-1-A2 type.
Very good point.
And this is the V effect. So when we pass the nail through the fracture, so with the nail in the fracture side, we cannot reduce this fracture. So it will obstruct the fracture reduction. So it will cause a varus collapse. So this will go this side, and this causes a varus effect. So Hugh et al. Study, in Hugh et al. Study, the advisor having an assistant holding the greater trochanter while the surgeon performs reaming at a high rotational speed. That means when we insert a nail, before insertion of the nail, we have to take power reamer and we have to insert the power reamer into the entry site, and by holding one surgeon with the pressure on the greater trochanter, we have to ream it with a high velocity. So then the reamer can create a hole, so the hole will accommodate the nail and the reduction will be possible. So, and it was concluded that the V effect which contributes to the hip varus deformity and non-union was avoidable with this method. So this is a Hugh et al. Study outcome. So this is the image showing the V effect, and this is a V effect X-ray depicting the V effect. So conclusions of the study: the three implant types are compared based on their complication rates and clinical outcome, and the intertand nail comes out on top. So we consider that intertand nails will be an ideal choice for femur fracture due to their relatively short surgery and fluoroscopy times and high postoperative clinical outcomes, clinical score, and lack of Z effect probability and low V effect rates which were mentioned rarely in the literature. So in the literature the mentioning about V effect is very less. There are only few studies which are conducted regarding the V effect.
Can you take this photograph? Photo చూపిస్తావా?
అది సేమ్ ఇదే సార్, అది
ఈ బొమ్మ చెప్పాలి. సో
ఇది మీరు పంపించిందా సార్?
అదే ఇది ఈ బొమ్మ పెట్టావా?
ఆమె పెట్టలేదు సార్.
So the improved patient outcomes depends on zero incidence of neck non-union, uncontrolled collapse or Z effect at 1 year. Patients had shortening in 73% of cases. Only 27% of cases had mild shortening. When you say mild shortening, it should be less than 5 mm. When you say mild shortening, it should be less than 5 mm. When you say moderate, it goes from 1 mm to 2 mm or 2.5 mm. Anything more than 2.5 mm is severe shortening. That is not acceptable. That is also one point. 90% of patients recover their pre-fracture functional status according to the Harris score. There are other scores also there, but you are interested in Harris. What is important of Harris score versus Oxford scores? Oxford score is only for orthoplasty. Oxford score is only for orthoplasty, whereas Harris score both for infection and trauma. This point is given in Campbell. Harris score is both for trauma and for infection, especially tuberculosis and other things. Whereas Oxford hip score only for orthoplasty. In other cases, we should not use the Oxford hip score. Yes. This is the point. You would have lost a bit. Conclusion there. Sorry. Very important.
And specialty about this study is they have included the V effect, sir. In the previous studies, they have not included the V effect, which caused significant failure on non-unions.
PFN lo undi. And you have got a reduction. Criteria. What do you mean by positive? What do you mean by neutral? And what do you mean by negative? Negative means the distal fragment comes medially. The distal fragment comes medially is called negative effect. The proximal and distal both fragments comes in alignment. That is neutral effect. If the distal fragment goes lateral, it's called positive effect. That is also should be. That effect also be discussed in relation to PFN. Okay. I will use the one. Yes. Yes, sir. Go ahead. You need one now?
One, sir.
Yes, sir.
The other case is done in first unit, sir. The 25 years male patient with grade 2 compound middle third sharp fracture of the right tibia with no comorbs, and there is a comminution at the fracture side with a separate fragment at the fracture side, and this is the
Like a butterfly fragment?
it is not like butterfly fragment, sir. It involved only one side cortex, only half of the cortex,
It's a wedge fracture.
yes, and the remaining half is like a transverse fracture, sir.
No, what I'm talking about, the fragment is a wedge fracture or a butterfly fracture.
It is like wedge fractures.
So type 2. So simple fracture, wedge fracture and comminuted fracture. AO-OTA classification for diaphragm fractures. AO-OTA classification for diaphragm fractures of the long bones. Number 1 is simple fracture. Simple fracture may be transverse or short only or short fracture. Type 2 are wedge fractures. Type 3 are comminuted fractures. It may be segmental or comminuted fracture. Yes, sir, go ahead.
And we did close reduction and dam fixation with IL lens, sir.
All is well.
All is well.
So what about the wound state infection? All controlled.
All controls.
So no major problem. So is there any spike, post-op spike at the time of surgery? What any difficulty?
No, sir, no.
Here and healthy.
Patient is young patient, sir. He is healthy, yes.
So no deep infections.
No deep
No
infection.
spikes.
No spike.
Very good, sir. Yes.
10 years male, sir, with closed lateral condyle fracture of left elbow with no distal neurovascular deficit. By posterolateral coccus approach, we have done open reduction and internal fixation with 2 KYs.
What type of cable? The divergent parallel.
More crisscross, not divergent.
So what is the complication of lateral condyle versus medial condyle? Where
Lat,
non-union occurs,
not,
where non-union
more
occurs?
non-union occurs in lateral condyle
Why?
fractures.
Why?
Because it is like avulsion fracture is one.
Yes, next point. Go ahead. Next.
So 55 years male, sir, intertrochanteric fracture of right femur, Boyden Griffin type 2. I have done closed reduction internal fixation with proximal femoral length for right femur, sir.
What about the lesser trochanter? Displaced, separated. What about the effect? It's a neutral effect. What effect is there? Reduction. Is it reduction?
It is neutral, sir.
Neutral
It's
effect.
neutral. So reduction is neutral. Yes. Okay. Yes, sir. Go ahead.
And 48 years male patient, sir. It is a closure bimanular fracture of the left ankle. It is a supination external
What is the other name for bimanular fracture?
parts.
Subperceval part. Subperceval part also describes the bimanular fracture, but he cannot able to describe the fracture with evidence. What is the evidence? Levi-Hansen classification based on clinical, radiological and experimental studies. Levi-Hansen classification is based on clinical, radiological and evidence-based experimental study. Evidence and experimental. So you cannot able to explain. You said it is a bimanular fracture, but you cannot able to explain. That's why subperceval part has been not accepted for the evidence-based medicine. Yes, sir. What?
So this is a transverse fracture of the medial malleolus and the fracture of the distal fibula above the syndesmotic level. So there is a supination externalization type of injury, and we did open reduction and fixation with a 9-hole semitubular plate for the distal fibula and a malleolar screw for the medial malleolus.
Which is fixed cost.
Fibula
To maintain the length.
To maintain the length and simple mortise and ankle mortise.
Yes.
Ankle open. Is it cannulated, non-cannulated? What type of screw is it? Manual screw?
Non-cannulated.
Non-cannulated
How many
manual.
screws are there?
2 screws are there.
Screws are there. So first you reduce with the K1 or directly pass?
So reduced
Reduced with the cable.
and we fixed it with a clamp and we have
Yes. By looking into the medial malleus, you can describe the ankle injuries or abduction injuries or abduction. If the abduction injuries are there, the medial malleus fractures are cancers. If there are adduction injuries, the medial malleus fractures are
Vertical,
That's
oblique.
also one simple study. So Leguhansen classification divided into, fine, go back sir, go back. Leguhansen classification has been divided into supination, adduction injuries, pronation, abduction injuries, supination, external rotation, supination,
Pronation, external rotation.
pronation,
External rotation.
vertical compression, syndesmotic, syndesmotic and unclassified. What is unclassified classification?
No severe injuries like rollover injuries or severe
What
accidents.
is unclassified classification for a miscellaneous or unclassified classification for ankle injury? Yes, Bharat Raja. Yes, yes, no, no. Yes, next, Abhi. Honey, where is the finalist? Your final letter. Injured final letter. The unclassified miscellaneous injuries, ankle sprain. Ankle sprain is also part of ankle injuries, but it is not included in classification. That classification is given by AMA, American Medical Association. 1. The ligaments are just stretched. 2. Partially strong. 3. Completely torn. Can you repeat?
1 is stretched and 2 is partially torn, 3 is completely
What is
torn.
the classification?
American Association.
American Medical
Medical
Association. Yes, American Medical Association for what?
For ankle sprain.
Which has been not described included. That is also one of the రాసేటప్పుడు పాయింట్స్ రాస్తే 5 మార్కులు 7 మార్కులు డిఫరెంట్ పడిపోయి కరెక్ట్గా చేస్తాడు మాట ఎగ్జామ్ ఓన్లీ హెడింగ్ చూసాడు మొత్తం అంతా చూడు అసలు అది ఉంటేనే అది ఉన్నాడు సామాన్ అసలు సామానే లేదు ఇదే చూస్తాడు మ్యాటర్ లేదని
Next patient, 17 years male patient sir, with 2 years old proximal middle third junction shock fracture of the left femur with implant in situ, that is TENS, and patient complaining of pain at the entry site sir with the, so these are protruding out, not penetrated but protruding sir.
Is there any skin injury, no injury?
No skin injury, not protruding sir, not came out.
So what are done?
We did implant removals.
And what are the above two?
Surplus.
Circulages we cannot remove.
Circle means you have opened the fracture. That time, how many
Yes,
years back?
2 years back.
Why circulars? It's a big,
It was like a spiral fracture sir,
long spiral.
long spiral.
You have not touched the anatomical. So you have not touched the circulars. Okay, right. 16 years.
16 years female sir with closed both bone fracture of left forearm sir. I have done open reduction internal fixation with 6 hole small DCP for left radius and 8 hole small DCP for left ulnus.
So, which fracture is fixed first? Radius or not?
Here we fixed radius.
Why? Is there any principle? No principle. So where is the fracture? Upper third, middle third, lower third?
It's middle third.
Go back. Clear.
We can fix either of the bones sir depending on the fracture type. అది కాదు sir, to maintain the length.
So where is the radius? Radius looks like
Proxim.
radius upper third. Ulna looks like
Middle third.
So you have both the fracture principle only. You have to open both the fractures. You have to open both the fracture. Ulna radius rendu open chestukoవాలి. First you have to open the radius, see that you can get in advanced reduction. Then you have to open the ulna. You are getting anatomical reduction ulna. అన్ని చూసుకున్న తర్వాత then you have to fix radius first. First is check that you are going to achieve on table the anatomical reduction. Then you have to go for radius fixation first. But you have to check both. Why sometimes you won't get the reduction? Which bone can be shortened? Bharat Raja, radius can be shortened, ulna can be shortened. Ulna can be shortened. So that is the principle. And both bones grow. Textbook earlier people used to say what you call that Watson zone. Places would be ulna is axis bone, ulna is axis bone. So the principle should be very good important. So now we have got a Rockwood green. In Rockwood green, there is a one column. He don't want to go in any controversies. He says authors preferred method of management. He gives his own ideas. నీ బాధ నీ మమ్మల్ని ఎవరు బాధలు వాళ్ళు ఉంటాయి అంతే కదా రాముడే నీ బాగా చెప్పుకోవాలి అట్లా చెప్తాడు ఆయన Very good point, excellent. That is all for now. Yes, sir.
Next patient, sir, 50 years female patient with a closed both bone fracture of the left forearm at the middle third, both sharp, and there is no combination. And I did open reduction internal fixation with 6-hole small DCP for right radius and 7-hole for ulna.
Yes, sir, next.
74 years female, sir, with intertrochanteric fracture of right femur.
Clarity, zoom there.
Okay.
Yes, okay. What is type 1, type 2, what and different?
Type 1, sir. And
Not
this,
too many. Clarity, sorry, coming.
yes.
Which are for you?
Closed reduction internal fixation with proximal femoral nail for right femur.
It is also called cephalomedullary
Nail.
fixation. What is the reduction? Anatomy.
Neutral.
Positive.
Neutral.
Neutral.
Neutrals.
Very good, excellent. Next. Just next.
And 40 years male patient with a closed both bone fracture of the right forearm at the distal and middle third junction. And there is a mild combination for the radius and as well as ulna. For the ulna, it was like a butterfly fragments.
Okay.
And we did open reduction internal fixation with a 9-hole DCP.
Yes.
No bone grafting.
No bone graft.
Anatomical reduction achieved.
Yes, sir.
Both construct.
Both construct.
Both of DCP.
Both are DCP, yes,
Very
sir.
good, excellent. Next.
And 63 years male patient, sir, with fractured neck of right femur. So this is almost subcapital type of fracture with a minimal combination on the medial side. And we did the cemented bipolar hemiarthroplasty.
Size.
I was not there, sir, probably 42, 43.
Next, I will. So your size also plays important. Go back.
Yes, side also, ma'am.
Your size also plays an important role. Why? What is the pelvic axis? You got the transverse axis of the knee joint, transverse axis of the ankle joint. Is there a pelvic transverse axis? Yes. The pelvic transverse axis
Bitrochanteric.
teardrop to teardrop. It is called pelvic transverse axis. It's good. No shortening, no limb line distal. Yes.
No.
Okay. Next.
So 46 years female, sir, with closed peri-implant fracture of right radius. It was done 4 years back, sir.
What plate is it?
So LCP, Ellis type,
Ellis plate.
Ellis.
plate.
Ellis.
3-hole LCP.
Yes. How many years old?
2 years old, sir.
Wait so far.
She had again recent trauma and had a fracture.
Okay. Yes, sir.
Had done open reduction.
Redo with the long plate.
Yes, sir.
Bone grafting, no bone grafting.
No bone graft.
All is well.
Yes.
Just next. It is looking like overall bottom or sometime back. Previously. 2 years back. 3 years back.
She was not operated.
So how many years old?
It's 2 years old, sir.
Yeah, go ahead. Yes, yes.
76 years male patient, sir, with the closed proximal third shaft fracture. Mason.
Masons.
Type 3 neck. Type 3 neck. Good morning, sir. The next is 76 year male patient, sir, with a closed proximal third shaft fracture of the right ulna with a radial head with a radial head and neck fracture of the right radius with no distal neurovascular deficit and no coma, sir. And the fracture is it has a butterfly fragment. It has a butterfly fragment on the ulnar side, sir, and the radial head, the radial neck is completely shattered, sir. It was like combinated with the neck, and the head is almost intact, sir. And we did open reduction and internal fixation with a 9-hole recon plate, sir, for right ulna through the regular Henry's approach. And during this approach, we identified the supinator muscle and we secure the radial nerve, sir. Posterior.
So you expose the radial nerve.
Posterior.
Yes, a posterior intraosseous nerve. Because it is a proximal fracture, we have to open.
What what type of fracture is it?
And it is a
Masons.
for the radial head, it is Mason's type 3, sir, with a combination of the neck, and it is a Monteggia type of fracture with a medial side ulnar fracture with a radial head fracture dislocation.
So it's a Monteggia variant.
Sir, yes.
So what is the standard Monteggia fracture?
It is a proximal third ulnar fracture with a radial head dislocation.
Yeah. So this is the variant. It's not dislocation.
Yes, sir.
There is a fracture. So still it's a fracture dislocation.
Yes, sir.
Okay.
And for the radial head, we did open reduction and fixed with KY, sir, 1.5 mm KY. and we immobilized the patient arm with the above.
What else you can use for radial head?
Yes, a radial head, separate design plates for there,
Plates
sir,
are
for the
there.
radial head.
Okay, go on.
So 55 years male, sir, with closed bimalleolar fracture of left ankle and undisplaced fracture of the left calcaneum, sir. This
How many days old?
so 3 days old, sir, at the time of admission.
Okay.
The status of the wound at the time of admission, sir. And Log and Hansen's classification, it is type 2 supination and external rotation type of injury, sir.
So what is the most important thing in ankle fractures?
Yes, sir.
We have to check for syndesmosis whether it is injured or not.
No, you can see there.
The ankle fractures are more prone for the non-union, sir. And the medial.
Oh, before that,
Swelling and
swelling, blisters.
Yes.
If you don't treat them immediately, there will be swelling,
Yes.
blisters, and what is the ideal time to treat them?
Yes, sir. After a week, sir. After a week.
After a week.
Yes, sir. For the complete subsidence of after complete subsidence of
If they come
edema.
immediately,
This patient came 3 days after.
no, if they come on the same day, what do you do?
if swelling is not there,
How long does it take for swelling to come?
So, minimum 24.
minimum 3 to 7 days.
Around 24 hours. Sir. Yes,
It will take, oh yes, minimum 24 hours. So the best way within 24 hours. Ankle fracture should be treated on the same day.
Okay.
Immediately you should keep them elevated and back slab, support them and treat them on same day. If you miss the day, then you wait for a week. Not every ankle fracture should be treated for a week. Okay.
They
ఇక్కడ
had an
వచ్చి అది ఇది చూపించుతున్నా ఒక్క దగ్గర కాదు మాట్లాడింది వస్తుంది ఎక్కడ రాదు కదా మేక్ షూర్ ఇది ఇక్కడ ఉంటే చూసి ఫోకస్ చేసినందుకు ఎవరు డిస్కస్ చేస్తుంటే వాళ్ళు చూపించాలి కదా
Yes, sir.
దాన్ని కనెక్ట్ చేసినావు ఎట్లా కనెక్ట్ చేసినావు పైన ఏ కనెక్ట్ చేసినావు
Yeah, okay.
say 45 years female, sir, with closed middle third shaft fracture of the left clavicle with no distal neurovascular deficit. Criteria for fixing this clavicle fracture is committed and she is a daily wage laborer, sir. And significant three part comminution is seen. So
What is the classification?
Allman classification is
Allman.
there for clavicle
Ah.
fracture, sir.
Ah.
Middle.
Identity is group 1 with middle third shaft.
So what type is this?
Group 1.
Group 1.
Yes, sir.
To complete dislocation.
Group 1 is middle third shaft fracture.
Okay.
Group 2 is distal. In group 2 we will see whether the conoid and trapezoid parts of the coracoclavicular are involved or not. And group 3 it is mainly involving AC joint. The fracture extending
And,
to the AC joint.
So in group 2, we talk about only middle third shaft fracture, sir. That is type 1 is undisplaced, undisplaced, and type 2 is completely displaced, sir. 100% displaced. So in type 3, the lateral third fractures. Then we talk about conoid and trapezoid ligament injury, whether it is there or not, sir. And we have separate classification also.
Based on
Leeds
displacement.
classification.
Ah.
Yes. So that
What is
is
that?
complete type 6 types are there, sir. Whether the conoid and trapezoid ligaments are intact, or whether the epiphyseal injury is there or not, or whether the comminution is there or not. So they have taken these 3 into consideration. They are divided into 6 subtypes.
So when do you fix them?
So for the clavicle fracture, the indication for the surgery is open fracture and tenting of the skin and neurovascular deficit, comminuted fracture and segmental fracture with the lateral third fracture with the ligament injury and AC joint disruptions.
And displacement greater than 2 centimeters in the fracture fragments. And bilateral clavicle fractures.
Okay.
For this we had an open reduction with 7-hole plate for left clavicle, sir. The plate is placed anteriorly with 2 circular joints.
Okay. Done, anybody?
ఉన్నారు సార్ చూసాను సార్
sir. These are the cases done in unit 3C. A 64-year male with 3 months old
Close to the mic. Yeah.
3 months old intertrochanteric fracture of right femur.
Okay.
We had close reduction internal fixation with proximal femoral nail for right femur.
Right. Okay. You're happy with the reduction?
Yes, sir.
Okay. Next.
40 years old male with bilateral closed comminuted calcaneal fracture, sir. It is on left side it is division type of fracture. On right side it is a tank-shaped fracture, sir. Here the CT film, sir.
Right.
And we have managed the case with percutaneous CC screw fixation.
So close reduction.
Yes, sir. Closed.
So what are the things you should look for? Whether the reduction is satisfactory or not?
We have to check for the articular surface of subtalar joint, sir, and followed by the calcanean height, and the calcanean width must be shortened, and we have to look for the calcaneofibrous space, and we have to look any involvement of the calcaneocubital joint, sir.
So height of the heel is important, width of the heel is important for normal walking, isn't it? Same time, you have to see the subtalar joint, whether it's reduced properly or not. And what's the angle for subtalar joint to see the proper reduction?
Angle of kisses, sir.
No. So how do you measure that one? Show me there.
Angle of kisses is measured from the anterior articular surface and the posterior articular surface of the joint, sir.
How much is normal angle?
It is obtuse angle, sir. So around 120 degrees.
No. So you can see better on this view, on your left side.
Yes, sir.
Okay. What do you think? How much is that?
It is more than
Jagdish knowledge.
Knowledge.
Okay.
Yes, sir.
Okay, go on. Careful. How many cases are pending? You need one?
4 cases.
You need two?
3 cases.
You need three?
అరే ఒకసారి ఇక్కడ
Okay, go on. Madam.
చూడు సార్.
వస్తుంది. The other case is done in unit 2, sir. 69-year-old male with 15.
Take your mask off. Close to the mic.
59-year-old male with
Raise the mic up there.
69-year-old male with 15 days old bimalleolar fracture, sir. It's a supination external rotation type of injury. We are fixed with open reduction internal fixation with malleolar screw for medial malleolus and
Close to the mic.
and plating for lateral malleolus.
Okay.
65-year-old female with intertrochanteric fracture of right femur, sir. It's a Boyden Griffin type 2 fracture, sir. We are fixed with proximal femoral nailing, sir. Closed reduction internal fixation with proximal femoral nailing.
Okay.
That's it, sir.
So That's, I think, the
can switch off. बंद कर. Transmission.
Sure.
Yeah.